The presenting complaint. This is the chief complaint or complaints about which you have been consulted, and as a consequence, a significant part of the consultation time will be devoted to this section of the case history. It is the most vital part of the inquiry, so ensure that the patient is allowed to tell their story with as little interruption as possible. Begin with a general invitation to talk, like, "How can I help you today?" If required, allow the patient a few moments to compose their thoughts, as on some occasions, patients may have so much to say, they may not know where to begin. A prompt may be appropriate. For instance, the patient may say, "I have been having quite a few different problems lately. What shall I tell you first?" You can respond by saying, "Why don't you start at the beginning of your problems?" Or they may say, "I have been suffering with so many aches and pains all over. Where shall I start?" You can respond by saying, "Why don't you start with what bothers you most, and then we can deal with any other problems later." During history taking, it is important to maintain eye contact, but do not stare at the patient. Do not become overly preoccupied with note-taking or engaged in the constant entering of data on computer-based systems. If information is coming too fast to write, you can ask the patient to pause for a moment whilst you make a record of important key facts. Avoid using technical terms or jargon. Use only simple, everyday language. Encourage the patient to tell their story by gestures such as nodding, saying yes, or "please tell me more," and the use of other suitable prompts. However, it is strongly recommended that at the beginning of the case history, you interrupt the patient as little as possible. The opportunity to clarify information will arise later on. Where a patient has numerous conditions or problems, establish a plan for action in collaboration with the patient. Identify the priorities and decide what you will be able to achieve during the limitations of the current consultation. Another way of grouping multiple complaints is to classify them into those requiring urgent treatment and those needing symptomatic relief. It is particularly important to start the consultations with open questions. Even though the patient may take control of the interview and veer off track, the clinician can always politely redirect them. Open questions elicit more information in a relatively short time than a steady stream of closed questions. This also prevents the patient from responding only to the narrow field specified in a closed question, or worse, giving you the answer contained in the closed question rather than what they would have volunteered if left unprompted. The following are some examples of open and closed questions. Open questions. Can you describe the pain in your leg? In contrast to, is your leg pain sharp or dull? Open questions. Do you feel pain anywhere else? In contrast to, does the pain radiate down your leg? The use of open questions may also set a more personal tone to the consultation and establish a more trusting relationship between the clinician and the patient. The employment of open questioning also avoids the situation where a false response may be given by a patient attempting to please a clinician by giving what they believe to be a correct response to a closed or leading question. When taking a history, it may prove useful to adopt the funnel technique of questioning. This term refers to the practice whereby open questions are used initially to elicit the maximum amount of information. More restricting and clarifying follow-up questions can be used later once the important areas of inquiry have emerged. Clarify uncertain words or descriptions used by the patient. Pain and palpitations, for instance, can mean different things to different people. If the patient can't be clearer, then offer them as many alternative descriptions and definitions as possible. Again, when trying to clarify terms, avoid leading questions. For example, if the patient has complained of having palpitations, do not lead them by asking them, "Do you mean a racing heartbeat?" If they can't volunteer a description of their own, then offer them several options, such as, "By palpitations, do you mean your heart feels as if though it's racing, thumping, missing a beat, fluttering, or beating irregularly?" and so forth. Similarly, if a patient finds it too difficult to describe their symptoms without help, you can minimize any bias you may be introducing by offering them a choice of terms to select from. For example, which term best describes your pain? Aching, burning, stabbing, shooting, stinging, or none of these? It is important for you to listen actively and also to watch out for clues such as facial expressions when the patient is describing relevant symptoms, emotions, and events. You may then guide the patient to tell you more about these areas. You may employ techniques such as facilitation, reflection, and empathic response to guide patients without diverting them from their own accounts. Facilitation is the use of posture, actions, or words to encourage the patient to say more without specifying the topic. For example, leaning forward, making eye contact, saying or "please go on." Reflection is the repetition of the patient's words that encourages the patient to give you more information. For example, patient: "I only drink alcohol at weekends when I go out." "Well, usually." Practitioner: "Usually?" Patient: "Well, sometimes I have wine at home during the week, but not every night." Practitioner: "Not every night?" Patient: "Well, only 2 or 3 nights during the week, at most." In this example, if we hadn't used reflection, we might have just noted down that the patient is an occasional or light drinker. As it transpired, this was not the case. An empathic response is one way of showing patients that you are not judging them for behaviors or feelings about which they may feel embarrassed or reluctant to discuss, but which are important to your understanding of their condition. Responses such as "I understand" or "You must have found that hard to deal with" may be appropriate. These make the patient feel more secure and encourage them to tell you more. Paraphrasing the information given to you by the patient and feeding it back to them is another technique that can be used to foster effective and accurate communication. A careful assessment of the character of any pain experienced by a patient is invaluable in determining the nature and extent of their underlying pathology. When listening to a patient's description of pain, the 4 general sources of pain and their characteristics should be considered. Broadly, these are somatic, neurological, visceral, and psychogenic. Details of these can be found in the slideshow. At the end of this section, when you think the patient has volunteered enough information on their presenting complaint, attempt to get behind their problem by expanding on the history.